Hi, everybody. Good morning to the Europe colleague and good afternoon to the Chinese colleague. In this special moment, we join together to have the web meeting for anti-COVID-19. Today, there are different countries. Here is from mainland China. Professor Zhong and me, Xue Li is also from the first hospital of Guangzhou Medical College, and also from Germany, Professor Hertz, chair the Germany meeting, and another is from Italy, Dr. Covetta, and also from UK, Professor Bentham from UK, and there's also and another country from Romania, Mr. Freddy Grace, and also from the Hong Kong mainland, Dr. Bin Len. So please, Professor Lam, you have to say something.
Hello, everybody. Welcome to this web meeting. So today's the agenda is like this. First of all, colleagues, experts from mainland China, from Italy, Germany will talk about the condition of COVID-19 in their country and also the strategy for the treatment of COVID-19. And there will be also experts from UK, from Romania, talking about the condition there. And after the presentation, we will have a Q&A session to have a hot discussion. And at the same time, we will be receiving questions online. And then by then, we shall try to address the questions based on your view on this point. And first of all, without further ado, I would like to introduce the first speaker. First speaker is Professor Zhongnan Shan. Zhongnan Shan actually does not really need any introduction in Asia, in China. Even non-medical society knows Professor Zhong well because he is the leading figure in the war against SARS 17 years ago and also against this COVID-19. And Professor Zhong is an academician of the Chinese Academy of Engineering, and he is actually the leading expert in pulmonology in China. And he will talk about the strategy for anti-COVID-19 in China, and followed by his talk, then Professor Corbetta, I know it's actually as Professor Bartoloni will talk about management of COVID-19 in Italy, and followed by UK speaker, Professor Jonathan Van Tam, to talk about the condition there. And after that, Professor Li Xuyue will talk about how to do bronchoscopy safely in COVID-19 patients. And then followed by Professor Luo from the West China University. He actually worked in Wuhan for 2 months, in the past 2 months, and now he's still self-quarantined at home. And after that, I think that Professor Felix shall also talk about something in Germany or only chair the meeting. And then all the people will join the discussion part. And after that, we will try to address those questions via the internet. So now, first of all, let's invite Professor Zhong to give his view on the strategy on anti-COVID-19 in China and his wisdom for the world. Professor Zhong.
Okay, thank you, Dr. Lam. So it's a great pleasure to meet with you, our colleagues. And then I suppose in this limited time, so I would like to focus on a few points. So can I have the slides, please? like to talk a little bit about what's this China status at the moment in combating the new coronavirus infection. So I think that this is today's data. I think altogether it is really a great spreading, causing a pandemic in the world, all over the world, with more than 400,000 people infected, and also 18,000, more than 18,000 people with the morphology of 4.4%. So I would like to focus on some points. First is transmission features. As you know now, everybody knows that's a very strong human-to-human transmission of this COVID-19 infection. But I would like to focus on some of the patients who, without any symptom, but actually they are virus carrier, may be very infected. I mean, contagious of that. So as you know, the role of SARS coronavirus, new SARS coronavirus transmission. So of course, the direct contact and the main transmission role.
Okay.
There's no evidence showing the mother to child, the baby viral transmission during pregnancy. Whether they have some stool transmission, so remain to be elucidated. So, but that's the infectivity is pretty high. So we have to think about some way, like feasible, possible fecal, urine, respiratory transmission this way. So as you know that the outbreak of Diamond Princess cruise ship, so about 1/3 of the passengers will infected. It's not only based on face-to-face talking and then cause such a high percentage of infection. I think that's the first paper published showing that the asymptomatic person will have some infectivity. So this is one person from Shanghai attend the meeting, visit Germany, and two of his partners worked together. And then when he flew back, in that case, flew back to Shanghai, got symptoms, and eventually 2 or 3 days being diagnosed as having COVID-19 infection by PCR. And two of them, the partners, also get infected. So I would like to say the basic reproductive number, there are a lot of studies showing that, but I suppose maybe close to the reproductive number, maybe close to 3, something like that. So it varies from places to places, but at least it's much higher than SARS and MERS, of course, much higher than seasonal influenza. I think the point I would like to mention is to emphasize this virus loads are pretty high in the upper airway at the first few days of onset. So of course that's a big problem. So it decreases remarkably 1 week later. So what can we tells me about this? So we have to think about that's a very high basic reproductive number, close to 3, and also a very high mortality as compared with influenza. And also that's a transmission capacity to human by asymptomatic virus carrier. This is why now in China or in Hong Kong, there's very much concern about the importer. So, and also very important is that earlier the stage of patient onset, the higher infectivity. So this is something we are worried about. So, and also, so we should keep up clean and clear of the sure and exhaustive puke. So diagnosis, I'm not going to talk too much about that. So, but anyway, so usually we use in suspected patient, we use real-time PCR, virus RNA. But right now in China, we started using double check and have POC for IgM study. And I think this is something, the method. I'm not going to talk too much about that. So now, as I remember, in Hong Kong, there's also to test the sample in saliva. So this is the real-time PCR, and this is the IgM study. As you know, the IgM appeared. So IgM appeared in the here appeared. So in the early stage, or something like 7 or 8 days after infection, or 3 or 4 days after onset of the disease. So the point is, we should make some differential diagnosis, and also at this time, trying to differentiate the COVID-19 infection and influenza. So this is some, in China, we have been working by using some facilities trying to differentiate this two kind of disease, which is quite difficult to differentiate from the clinical part. So, and the third, I just basically pointed out about the clinical characteristics. So this is a paper that's published by our group, by Dr. Guan, and then collecting about close to 1,100 patients in 500 hospitals at the very beginning. So that at that time, the mortality is not that high, and our primary endpoint will be composite endpoint, either received admitted to an ICU or invasive ventilation or death. So you can see in this clinical analysis, the mean incubation time is 4 days, from 2 to 7 days. And then a very important point I would like to point it out is, so of course, the fever or cough and fatigue is most common symptom. But so in our groups, so close, more than 50% of the patients were actually a fever on admission. So that's a need to be very careful to see, because fever is not the golden standard for the symptom of the this COVID-19 infection. And also people should be noticed. So of course, more than 85% of patients have a CT abnormality with GGO, and bilateral infiltration is most common, in particular, distribute around the subpleural location. And the laboratory findings have found lymphopenia is very apparent index, elevated CRP, LDH, and direct bilirubin. And this is something we need to be very aware about that. This like the X-ray like this. So we actually had very important a study showing how to predict critical ill patients. So the predicted indices were around 10 points. Of course, the X-ray abnormality, age, hemoptysis, and dyspnea, unconsciousness, and number of comorbidities, and cancer histories, and neutrophil, lymphopenia, and LDH increase, and increase of direct bilirubin. So we'll put this together and make a prediction whether there will be a very serious ill patient or will be mild. So in terms of the management, so I think we are now doing some study at the moment. First, lopinavir and ritonavir, the Calitra, is first, and chloroquine, and IL-6 receptor antibody, tosinidumab, and this is a Chinese, traditional Chinese herbs, 莲花清瘟胶囊, and hydrogen and oxygen mixed gas inhalation, and also convalescence plasma and remdesivir. So far we have got some results. This is one presented by Dr. Chao Bin, and he have found with the primary endpoint, the time to clinical improvement, and some other. So Calitra, it didn't show some superiority as compared with the other treatment, either any kind of so-called antivirus treatment. Didn't show that. So it doesn't show very effective of this kind of Calitra in the management of COVID-19. And the second is chloroquine. And before we published the, we just finished the study, and now it's going to submit to the literature. And before that, some colleagues have found the chloroquine or hydroxychloroquine as an available weapon to fight COVID-19, and they have not actually had not done the study. So actually, from our laboratory, so we have found this is actually COVID-19, and that's the target protein is from 3D mode of chloroquine is based on this active site to 3CL of SARS coronavirus. And that the plasma concentration, if we use 500 milligrams per day, twice a day for 10 days, and the plasma concentration is this in this range, very much close to the EC50 of chloroquine against COVID-19 in the blood. So at this point, we had just finished a data showing. So we use open label, multi-center, non-randomized trial because it's difficult to make a randomized trial. And just show you the result because they are submitting this paper to the journal. The patient in chloroquine group had shown a shorter time to reach the undetectable viral RNA comparing with the control group, 3 versus 9 days, pretty good. So by the day 10 or day 14, they have higher proportion of patients have virus RNA turned into negative. So this is the percentage for chloroquine group, and this is the percentage for control group. It's much higher than this in the chloroquine group, and the duration of fever significantly shorter and in chloroquine group. This is the result, the primary result. So another is the TCM, Chinese traditional medicine, in particular, and this called LH QW, this one. And I think we have done some laboratory study and looking at that antivirus or anti-inflammatory activity for these Chinese herbs. I'm not going to talk too much about that. We just finished a clinical trial and have a control study. And for 284 patients receiving treatment and higher overall recovery rate in the treatment group as compared with control group. This is the result. And faster symptom recovery in the treatment groups. This is 7 versus 10 days, and higher rate of important improvement of CT scan manifestations. This is the result. And there is also clinical recovery in the treatment group. But however, we didn't find a significant difference in the conversion rate to, some of the patients turned into severe status, and and also the virus conversion time. So that's no significant difference, although there's a tendency with tendency towards shorter of this Chinese herb, but it didn't show significant difference. That's this paper is under review. And convalescence plasma, let's see. This is a data as in preprint data. The feasibility of convalescent plasma therapy in severe COVID-19 patients. A pilot study is in press. We use the recover donors with the neutralizing antibody titers about one versus 640, and 10 patients, just one dose, 200 mL convalescent plasma, and primary endpoint, the safety of convalescent plasma transfusion, and secondary endpoint is improvement of clinical symptoms and laboratory parameters within 3 days after the transfusion. And this is the primary result. You can see both CRA and lymphocyte and alanine, so aminotransferase and aspirate, aminotransferase, and total bilirubin. It also shows in, except for total bilirubin, the other seems to be improved, lower, or going down, and the lymphocyte seems to be a little bit better, and oxygen saturation is also getting better, and this is also on the time, on the way for publication. And in particular, it's important as a comparison of the serum neutralizing antibody. So you can see the virus load here, and also antibody, so titers. You can see or increase, and also the serum virus loads all turns to negative. So that's the primary result. That's the before and after, And then some special issue. I suppose my time is over, so I have to skip from this study. And then finally, I would like to talk a little bit about the China strategy in controlling further spreading. So as you know, we announced, including Professor K.Y. Yun, and we announced so that the definite human-to-human transmission, and also confirmed that medical staff have been infected at the day of 20th January. The central government had taken very strong action, lockdown Wuhan, so, and also mentioned about don't go to Wuhan, don't leave Wuhan, and the so-called real-time announcement of the number of the diagnosed and suspected patients every day in each city nationwide, and the so-called interagency mechanism launched. So this interagency action is down to the community, the so-called early self-protection, early detection, early diagnosis, and early isolation. So this is something happened in Wuhan at that time. I would like to mention about this because in Europe, in your country, that's still at the first wave. So we just take the action on the 23rd January, and reaching the highest just 2 weeks later, reaching the peak. And after that, it's going down. So eventually, after 1 month, 4 weeks, so return to the basic control. This is one thing. And you can see here, so this is in China from the end of January to the just 2 weeks, and then reach the peak. Up to now, still is a plateau. But in some of the countries, you can see, so very low and very few, and then start to increase in the 7th of March. And then after that, that's 3 weeks, it's going up strictly. So this is what we have made a prediction. So this is, we are on, and also validated that in real time, that's the curve actually now happened. If we announce this, we give this strategy a little bit earlier, 5 days earlier, then we would like this. If we'll 5 earliest late, then we would like that. So the peak will be 170,000 patients in China. So this is the real situation in Italy, the United States, Spain, Germany, Iran, France. So now still going up at the moment in this curve. I suppose we should have some action towards the very strict. So the lockdown, the high outbreak area, and then have a very strong for early, the so-called self-protection, self-detection, self-diagnosis, and self-isolation. So thank you very much.
Thank you, Professor Zhong. Thank you very much. And we will leave the discussion part later.